Welcome everyone. My thesis title is Treatment-Related Cardiotoxicity in Pediatric Oncology. My name is Nóra Beke. I'm a PhD student, and my vision is that cancer patients should live a high-quality life without heart complication. And my mission is that encourage the attitude that clinical practice and research are inseparable. My first project title is Cardiotoxicity in Pediatric Oncology. This is a systematic review and meta-analysis. Although the 5-year overall survival of children with cancer is 80%, we pay a heavy price for it because of the serious cardiotoxic side effect of the treatment. Cardiovascular diseases are the leading cause of late morbidity and mortality. Childhood cancer survivors have 5 to 15-fold increased risk for heart failure, and almost half of the patients have myocardial injury. Current guidelines suggest echocardiography for monitoring, but in many cases it does not detect early enough. Otherwise, we know several other screening modalities. For example, other imaging technique, blood biomarker, genetic variants, and microRNA. But so far, there is no study that compares their accuracy. Therefore, our study aim is to find out which modality is the most accurate in detection of cardiotoxicity, and if we succeed, we can make a recommendation for which tool should be used in order to minimize cardiotoxic side effects. It is an important topic because early detection allows us immediate intervention, so we can save lives. Our clinical question is, what is the most accurate prognostic tool for predicting therapy-related cardiotoxicity in childhood cancer patients? We use PFO framework. The population is children with cancer and childhood cancer survivors. The prognostic factors are cardiac biomarkers, echo, genetic variants, microRNA, and the outcome is the prediction accuracy of heart failure. Our hypothesis is that echocardiography is the most accurate prognostic tool in predicting therapy-related cardiotoxicity in childhood cancer patients. My search key contains 4 domains: pediatric cancer, accuracy, and cardiotoxicity. The hint numbers can be found on the bottom of the slide. After the systematic search, I had 5,000 articles, and at the end of the all selection phases, I have 73 eligible articles. Based on the type of the predictive factors, we divided the articles into 5 major groups: microRNA, echocardiography, AI model, serum biomarkers, and genetic variants. And the outcome is these factors' prediction performance measured by area under the curve, correlation, odds ratio, adjusted odds ratio, and mean difference. In this first forest plot, we have summarized some predictive factors, and in this case, they are investigated in a complex prediction model built by AI. We have plotted the time-independent performances of these following models. We used area under the curve as a unit which shows the quality of prognostic ability of these factors. The area under the curve is a region under the receiver operating characteristics curve, which shows that as we change the threshold of the underlying continuous variable, the sensitivity and specificity also change. The value can be varied between 0.5 and 1. 1 represents the maximum sensitivity and specificity, and 0.5 represents the result of random guessing. The figure shows that the performances are quite scattered. We used 3 cohort studies, and the heterogeneity here arises from the differences in the prediction models. We used 3 cohort studies, and we used the state-of-the-art values. The overall AUC value is 0.8, but we can see that ECG with clinical parameters reach 0.89 AUC value, which is an exceptionally high value. This suggests that clinical parameters alone are not enough. Additional examinations are definitely needed, and even then we cannot reach outstandingly good performance. In the next forest plot, we can see the prediction performance of some microRNA and high-sensitivity cardiac troponin T. We couldn't plot the results in this case because statistically it was not possible. The time means that how many hours after the chemotherapy they check the microRNA level. We used area under the curve as a unit, and we used 2 cohort studies. One of them defined cardiotoxicity based on troponin value, and one of them based on global longitudinal strain. Regarding the results, the AUC values are high. They can reach up to 0.9 AUC value, and this suggests that microRNA could be a promising predictive factor, but further studies and larger sample size are needed to prove it. Our study main strength that we try to create order in a chaos caused by a non-uniform publication strategy of the articles, and this will be a complex and comprehensive analysis of most of the predictive factors we have known so far. The main limitations are incomplete data provision and the diversity of the definition and the variables. That's why we couldn't pull the results in most of the cases. Our study conclusion is that detection of cardiac failure in pediatric oncology can be achieved with AI prediction models. The main implication for practice is that microRNA and AI models should be used in diagnostics, and the implication for research is that appropriate control groups are required, and the development of multivariate AI-based model could be a new way to improve the detection of cardiotoxicity. We submitted the manuscript to Lancet Oncology, and they offered us a transfer to Biomedicine, and now we are waiting for the decision. My second project title is investigating the side effects of immunotherapies in pediatric cancer patients. This will be a systematic review and meta-analysis. The most promising treatment in modern pediatric oncology are immunotherapies. These therapies work by enhancing the immune system ability to eliminate malignant cells. These therapies have been widely used in recent years, and the patients often receive them for years. That's why very important to know what their long-term side effect profile, and in the short term, they can cause colitis and dermatitis, and in the long term, they can cause endocrinopathies and growth retardation. However, so far, there is no study about these side effects. Therefore, our study aim is to find out. Therefore, our study aim is to provide evidence regarding the immunotherapy side effect. Our clinical question is, what are the side effects of immunotherapies in pediatric cancer patients? We use PO framework. The population is pediatric cancer patients and childhood cancer survivors. The exposure is malignant disease treated with immunotherapy, and the outcome is the side effect. Our hypothesis is that the use of immunotherapies does not increase the risk of side effects in pediatric cancer patients. My primary research case contains 4 domains: pediatric cancer, immunotherapy, and adverse effect, and the hit numbers can be found at the bottom of the slide. Currently, we're preparing the Prospero registration, and we would like to finalize it until the end of January. Since my vision is that pediatric cancer patients should live a high-quality life without any complication, I would like to support this with my 2 studies. I will end my presentation with the words of Ralph Waldo Emerson: all is a riddle, and Cato riddle is another riddle. Thank you for your attention.
Thank you for your interesting presentation. I just have one question regarding your first project. Have you come across studies that use the high-sensitivity troponin to predict early myocardial changes in this patient? And did it show to be a good predictive factor alone?
Thank you for your question. Yes, we included studies that examine the troponin prediction performance, but troponin didn't reach a really good performance in prediction.
Congratulations. So I have one question related to your first topic. So in the studies, what you examined, the patient receives the chemotherapy. Then we drew some blood, the microRNA or whatever is analyzed, and then that algorithm can predict the cardiotoxicity event of that patient. So does it change somehow the outcome or the treatment protocol of that patient? I mean, if I know one patient is sensitive to that given drug, I don't give it or give it in a different dose. But if I have already delivered it and he or she already received it, and I just see the cardiotoxicity earlier than in other situations. Is there any way to intervene or prevent the long-term side effects?
So the pediatric cancer patients monitoring for cardiotoxicity in echocardiography regularly. So they have some change in the heart. We can make a preventive intervention. It is not related to microRNA or AI-based model.
So you suggest that in the future, using one of these models, we can reduce the number of echocardiography needed in these patients?
Yes, I think AI-based model could be more perfect for monitoring because they investigated a lot of variable, and the echocardiography is just investigate one screening method. It is just one screening method.
And is there data about the sensitivity and the specificity of the echocardiography in cardiotoxicity?
Almost half of the patients can be detected with echocardiography, so 50%.
Thank you.
What about brain natriuretic peptide, BMP, pro-BMP?
We investigated them as well, but it was not so good in prediction because it was a really low sensitivity and specificity.